Welcome to vpod.ai and welcome to the Deep Dive, your shortcut to becoming truly well-informed. Today we're taking on a pretty complex but really vital medical topic, acute lymphoblastic leukemia, or AL. Our mission here is to quickly get a handle on what AL actually is, how doctors figure out a diagnosis, and also look at the innovative ways it's being treated now. We'll try to cut through some of that dense medical jargon, and deliver the key insights you need to understand this disease. Now, this deep dive is proudly sponsored by Stonefly. They're your trusted solution provider and advisor in enterprise storage, backup disaster recovery, hyper-converged VMware, Hyper-V, Proxmox cluster, AI servers, SA365, which is a turnkey security appliance, and also public and private cloud solutions. You can find out more over at stonefly.com. Okay, so let's unpack this. We hear these medical terms, they can sound pretty intimidating, but at its core, what is acute lymphoblastic leukemia?
Right. Fundamentally, ALL is a type of cancer. It originates in the blood and
The bone marrow. That's the spongy stuff inside bones.
Exactly. It's like your body's specialized blood cell factory. That's where everything gets made.
And those specific words, acute and lymphoblastic, what do they tell us? What's the significance there?
Yeah, good question. So acute is really crucial because it means this disease progresses very rapidly. It doesn't really give you much time. And lymphoblastic, that refers to the specific type of immature white blood cells involved. They're called lymphoblasts, or sometimes just blasts.
Blasts, okay.
Imagine your body's blood cell factory. Right. Normally, it's just humming along, producing perfect red blood cells, white blood cells, platelets.
Everything you need.
Exactly. Now, picture just one tiny master blueprint that's a stem cell having a sort of microscopic typo in its genetic code.
Just a small glitch.
A really small glitch. But that typo suddenly tells it to churn out only faulty, immature white blood cells, uncontrollably. It just overwhelms the whole factory. And that's really the core of LL. It's a single, seemingly tiny change that spirals into this massive disruption of the body's entire blood system.
Wow. So if these abnormal lymphoblasts are just flooding the factory, what happens to the healthy cells we actually need?
That's exactly the problem. These abnormal lymphoblasts, they multiply so fast, they crowd out the healthy cells your body desperately needs to function.
Right.
So a lack of healthy red blood cells, that can lead to severe fatigue, weakness, maybe breathlessness.
Makes sense.
A shortage of the functional white blood cells leaves you really vulnerable to infections, sometimes life-threatening ones, because your immune system is basically compromised.
Right.
And low platelets mean your blood can't clot properly. So you might see easy bruising, nosebleeds, or even dangerous internal bleeding. It really hits the whole system.
So when these kinds of symptoms start showing up, how do doctors even begin to piece this together? Diagnosing AL sounds like it must involve a lot of steps.
It absolutely does. Yeah, it's comprehensive. The critical first step is usually something called a bone marrow aspirate and biopsy.
Okay, what does that involve?
Well, these procedures involve taking samples of both the liquid part and the solid part of the bone marrow, usually from the back of your hip bone. And for an AL diagnosis, doctors are looking for a specific percentage of these abnormal lymphoblasts in that marrow sample.
A threshold, basically.
Exactly. Generally, it's 25% or more for adults and 20% or more for kids. It's about confirming that these abnormal cells have really taken over a significant chunk of the marrow.
Beyond those very specific cancer tests, though, I imagine doctors need the bigger picture, right? The patient's overall health, other conditions, maybe even supplements they're taking. Why is that whole person view so important?
Oh, it's incredibly vital. Yeah. A thorough medical history is essential. You need to know about all past health issues, treatments. And it's also really important for patients to disclose everything they're taking. All medicines, even over-the-counter stuff, and any herbal supplements.
Why supplements?
Well, things like, say, turmeric or ginkgo biloba, green tea extract, St. John's wort, they can actually interact quite significantly with prescribed medications.
Okay.
Affecting how they work.
Exactly. Affecting efficacy or causing unexpected side effects. So full disclosure is key. And of course, physical exams are part of this initial assessment too, checking vitals, listening to organs, feeling for enlarged lymph nodes, things like that. Then there's a whole battery of blood tests that are just indispensable.
Right. What kind of tests?
Well, a complete blood count, or CBC with differential, that's almost always one of the first. It measures your healthy blood cells and helps identify abnormal ones. We also do chemistry profiles, liver function tests, LFTs, and kidney function tests, check how the organs are doing, because all L can affect them.
Okay.
Blood clotting tests are also crucial because, as I mentioned, leukemia can mess with the body's ability to clot. You might get too much clotting or too much bleeding. And then there's something called the tumor lysis syndrome panel, or TLS panel.
PLS. What's that?
This is a really critical test, especially right when treatment starts. When lots of cancer cells die off quickly, they release waste products into your bloodstream.
Like debris. Kind of, yeah. This panel checks key markers like uric acid and potassium. If those get too high, it can indicate kidney damage or severe electrolyte imbalances, which need managing fast.
Wow.
And finally, screening for opportunistic infections is vital. It often surprises people, but all treatment can seriously weaken the immune system.
Right.
This makes patients highly susceptible to infections that, wouldn't normally be a problem, but in this state, they can be fatal if not caught and treated really early.
That's a stark reality. Fighting the cancer itself, but also having this constant need to guard against these other infections, it must mean incredible vigilance.
Absolutely. Constant vigilance from everyone involved, the patient, the care team, it's crucial.
So once doctors have found these abnormal cells, the next step, I guess, is understanding their specific identity, like getting their fingerprint. How do they actually look at the genetic makeup of these leukemia cells? It sounds incredibly precise now.
It really is. We've come a long way. This is where some really sophisticated tests come in. Flow cytometry is one key method.
Flow cytometry.
Yeah, think of it like giving each cancer cell a unique ID badge. It's based on the specific proteins or markers it has on its surface. This helps us detect subtle differences between various blood cancers and precisely pin down its type and origin. We call that immunophenotyping.
Okay, so it's like sorting the cells very precisely.
Exactly. Then we have genetic and biomarker tests. These look specifically for mutations, changes in the genes and chromosomes inside the AL cells themselves.
Okay, maybe a quick refresher. DNA, chromosomes, genes.
Sure. So think of our DNA as this enormous instruction manual for building and running our bodies. It's tightly packaged into 46 structures called chromosomes. We get 23 from each parent.
Right.
Each chromosome contains thousands of genes, and genes are like individual instructions, usually coding for proteins. A mutation is basically a typo or a misprint in that manual.
Like a deleted word or...
Or a missing section, yeah. Or sometimes extra words get added or even whole sections get swapped between different chapters. That's called a translocation. In EOL, these genetic glitches are what signal the cells to just grow completely out of control.
Okay.
A really well-known example of that kind of swapping is the Philadelphia chromosome, often written as FH plus low.
I've heard of that one.
Yeah, it results from a switch, a translocation, between parts of chromosome 9 and chromosome 22. This creates a new abnormal fusion gene called BCR.ABL1. And it's important to know this isn't something you inherit. It develops spontaneously in the cancer cell.
Got it. So how do you find these specific changes?
We use methods like fluorescence, which stands for fluorescence in situ hybridization, PCR, polymerase chain reaction, and also next-generation sequencing, or NGS. PCR, for instance, is incredibly sensitive. It can potentially detect just one abnormal cell among, say, over 100,000 normal cells. It's that powerful.
That level of detail is just astonishing. But for a patient hearing about PCR, ABL1, or translocations, it must feel pretty overwhelming. So beyond just identifying the cancer subtype, how does knowing this genetic fingerprint actually change things for their treatment? Does it mean totally different drugs?
It's absolutely transformative, yeah. These sophisticated tests are crucial. They guide the entire treatment plan. They help assign patients to specific risk groups, like higher risk might need more intensive therapy. And, really importantly, they can even help predict how well certain drugs might work for that specific person.
So personalized medicine, basically.
Exactly. That's where pharmacogenomic testing comes in. It can help tailor dosing decisions. For example, some people have genetic variations that affect how they metabolize certain chemotherapy drugs. Pharmacogenomics helps figure out the best starting dose to avoid severe side effects, like myelosuppression, where your bone marrow activity drops too low. So understanding that fingerprint leads to a much more targeted and hopefully more effective approach. It's precision.
Okay, that makes sense. Now, beyond the cells and their genetics, how do doctors actually see where the leukemia might be hiding in the body? Are there ways to visualize if it's spread?
Yes, imaging tests play a really vital role here, too. CT scans, for example, use X-rays to create detailed cross-sectional pictures. A brain CT is often used early on to check for any bleeding.
Hmm.
MRI scans give even more detailed images, particularly of soft tissues like the brain. They use radio waves and magnets, so there's no radiation exposure.
That's good.
Yeah, and an MRI is particularly useful for looking for things like leukemic meningitis, which is when leukemia cells cause inflammation in the layers covering the brain and spinal cord. It's worth mentioning for patients, though, the MRI machine is quite enclosed. So if you experience claustrophobia, it's definitely something to discuss with your care team beforehand. They have ways to help.
Good tip. What about PET scans?
Right, PT scans. These use a radioactive tracer, usually a form of sugar. Cancer cells tend to be very active and gobble up more sugar than normal cells.
So they light up.
Exactly. They show up as bright spots on the scan, indicating areas of high activity. But a key point here, not all bright spots are cancer. Normal brain, heart, kidney, bladder activity can also be bright. And also, not all tumors will necessarily show up on a PET scan.
Okay, so it's one piece of the puzzle.
Definitely. And besides these, sometimes more specialized scans are needed. Maybe a scrotal ultrasound to check the testicles for leukemia involvement. And heart tests like an ECG, an echocardiogram, or maybe a MUGA scan are often done too, mainly to check heart function before starting treatments that could potentially affect the heart.
Right, assessing the baseline. Okay, so once the diagnosis is confirmed with all this incredibly detailed information, what are the main strategies? What's the battle plan for fighting all?
The core of all treatment really universally includes steroids and what we call multi-agent chemotherapy, meaning several different chemo drugs used together. Chemotherapy is typically given in cycles, so you'll have treatment days followed by rest days. This allows your body some time to recover between doses. And a really critical part of the chemo regimen is intrathecal chemotherapy, or IT chemo.
Intrathecal.
Yeah, that means it's injected directly into the cerebrospinal fluid, the fluid surrounding your brain and spinal cord, usually via a lumbar puncture or spinal tap. This is done to prevent the leukemia from spreading to the central nervous system, the CNS, or to treat it if it's already there. The CNS is, unfortunately, a common place for all to hide, so the CNS prophylaxis is standard.
That makes sense, targeting potential hiding spots. And that's the sort of traditional approach, chemo and steroids, which has been the mainstay for a while. But what about the newer, more targeted therapies? We hear so much about them changing the game. How have they impacted all treatment?
Oh, they've made a huge difference. This is where things have really evolved, especially in the last, say, 10 to 15 years. Tyrosine kinase inhibitors, or TKIs, have had a truly transformative impact, particularly for patients with that Philadelphia chromosome positive, or VH plus allele we talked about earlier.
Right, the BCR-ABL1 gene.
Exactly. Before TKIs, VH plus allele was notoriously difficult to treat. Really aggressive, often needed intense chemo. Outcomes weren't always great. Now, with TKIs, these are often daily pills like imatinib, dasatinib, ponatinib. These drugs specifically block the growth signals coming from that faulty BCR-ABL1 protein.
So they shut down the specific driver of that leukemia.
Precisely. And we're seeing patients achieve very deep remissions. It's offered not just much better survival rates, but for some, really the revolutionary hope of maybe avoiding or needing much less traditional chemo with all its side effects. It's been a massive shift for VH plus LL. Then we have immunotherapy. This is a whole different approach. It aims to harness the power of the patient's own immune system to find and fight the cancer.
Using your body's defenses.
Exactly. This includes antibody therapies, like blinatumomab. That's a clever one. It's a bispecific antibody. It basically grabs onto a leukemia cell with one arm and grabs onto one of the patient's own T cells, an immune fighter cell, with the other arm, bringing them together so the T cell can kill the leukemia cell.
Wow, like a matchmaker for destruction.
Kind of, yeah. Another type is inotuzumab ozogamicin. That's an antibody drug conjugate. It's like a guided missile. An antibody targets the leukemia cell, and it's carrying a payload of chemotherapy that gets delivered right to the cancer cell.
Very targeted chemo delivery.
Right. And perhaps the most innovative, really cutting-edge approach is CAR T-cell therapy.
So RT, yes.
Oh.
How does that work again?
So this is truly personalized. Doctors take some of a patient's own T cells out of their body. Then, in a specialized lab, those T cells are genetically engineered. They're given a new receptor, a chimeric antigen receptor, or SCAR, that specifically recognizes a protein on the surface of the leukemia cells.
So you're basically training the T cells to hunt the leukemia.
Oh, you got it. Then millions of these newly engineered CAR T cells are grown in the lab and infused back into the patient. They become this living drug, multiplying and attacking the cancer. Tisagenlecleucel, brand name Kymriah is an example used in AL.
Incredible. But I hear it can have some serious side effects.
It can, yes. Because it ramps up the immune system so much, it can cause something called cytokine release syndrome, or CRS, which can feel like a severe flu or worse, and also neurotoxicity affecting the brain. These require very careful monitoring and management in specialized centers.
Okay. So lots of powerful options. What about radiation or transplants? Are they still in the mix?
Yes, definitely. For specific situations, radiation therapy might be used to target leukemia cells in particular areas if the disease has spread there, like the brain or sometimes the testicles. And total body irradiation, or TBI, is often part of the preparation, the conditioning, before a hematopoietic cell transplant, or HCT, sometimes called a stem cell or bone marrow transplant.
Right. And for all, it's a donor transplant.
Yes, for all, we only use allogeneic transplants. That means the healthy stem cells come from a matched donor, could be a sibling, could be an unrelated volunteer, not from the patient themselves, that's autologous, used for other cancers. The transplant process itself involves that conditioning phase first. High doses of chemo, sometimes with TBI, are used to wipe out the patient's existing bone marrow, including any remaining leukemia cells, and also to suppress their immune system so it doesn't reject the incoming donor cells.
Sounds really intensive.
It is. After the conditioning, the healthy donor stem cells are infused, much like a blood transfusion. The goal then is for these cells to travel to the bone marrow and engraft, basically set up shop and start producing new healthy blood cells. This engraftment typically takes about 2 to 4 weeks, and during that time, the patient has very little immune defense, making infection risk very high.
So managing that conditioning intensity is key.
Absolutely. Doctors carefully choose the intensity of the chemo or radiation conditioning regimen beforehand. There's a balance. You want to be strong enough to kill the leukemia and make space for the new cells, but minimize the really harsh side effects and risks. There's ongoing research comparing different intensities, like reduced intensity versus fully myeloablative conditioning, looking at that balance between relapse risk and non-relapse mortality. It's complex.
It really sounds like a long and very involved journey for patients. What are the typical phases of treatment? And what happens if, the cancer proves stubborn or comes back?
It absolutely is a journey, and it's usually structured into distinct phases. The first big push is induction therapy. This is usually the most intense phase, using a combination of chemo drugs. The goal is to achieve a complete response, or complete remission, meaning no detectable signs of leukemia in the bone marrow or blood under the microscope.
Okay, get rid of the bulk of it.
Exactly. But even after achieving a complete response, we know tiny numbers of leukemia cells can still be lurking. That's where minimal residual disease, or MRD, testing comes in.
Ah, yes, you mentioned PCR can detect that.
Right. MRD tests are super sensitive lab tests that can find those very small numbers of remaining leukemia cells. Detecting MRD, even at low levels, strongly predicts a higher risk of the cancer coming back or relapsing. So a major goal of the next phases of treatment is often to eliminate any detectable MRD to get MRD negative status.
Okay, so consolidation.
Right. Following induction and MRD assessment, patients move into less intensive phases, generally called consolidation or intensification, and then maintenance. These usually involve different chemo drugs or schedules, sometimes over a longer period, all designed to kill off any remaining cells and prevent relapse. Maintenance can sometimes last for a couple of years.
But it doesn't always go smoothly.
Unfortunately, no. Sometimes the leukemia doesn't respond well enough to the initial treatment that's called refractory disease. That's obviously very serious. Sometimes the percentage of allo cells might actually increase during treatment that's disease progression. And if the cancer disappears for a while, remission, but then comes back later, that's a relapse. A relapse can happen back in the bone marrow, that's a medullary relapse. Or it can sometimes appear outside the marrow, like in the central nervous system or the testicles. That's called an extramedullary relapse. Each of these situations requires a change in the treatment plan, often involving newer therapies or considering a transplant if not done already.
Gosh, all these incredibly powerful treatments, the chemo, the targeted drugs, CRRT, transplants, they must come with significant side effects. How is all of that managed throughout this really challenging process? Sounds like there's a whole parallel system of just support.
There absolutely is, and it's critical. Managing side effects falls under the umbrella of supportive care, or sometimes palliative care, though that term can be misunderstood. It's not just end-of-life care. It starts from day one. The main goal of supportive care is really to improve the patient's quality of life by preventing or managing the symptoms of the disease and the side effects of the treatment.
Like what kind of things?
Well, common things like fatigue, pain, nausea, vomiting, there are good medications for those. But also managing complications. We talked about infection risk due to the weakened immune system.
Right, the opportunistic infections.
Exactly. So prophylactic medications, antibiotics, antifungals, antivirals are often given preventatively. For instance, medicine is usually given throughout treatment to prevent a specific serious fungal lung infection called pneumocystis pneumonia, or PJP. Patients are also at higher risk for blood clots, so sometimes blood thinners are needed.
What about other side effects from the drugs themselves?
Yeah, there can be others. Neurotoxicity can sometimes happen with certain chemos or CRT, causing things like problems with concentration, memory, confusion, or even seizures. Osteonecrosis, which is basically death of bone tissue, can be a side effect of high-dose steroids, often affecting weight-bearing joints like the hips. That needs careful monitoring.
Mhm.
High blood sugar is also a common side effect of steroids and needs monitoring and sometimes medication. So supportive care involves managing all of that. It also includes interventions like dialysis if the kidneys get damaged, perhaps by that tumor lysis syndrome we mentioned, or leukapheresis, a procedure to quickly remove large numbers of white blood cells from the blood if the counts are dangerously high at diagnosis. And of course, blood transfusions, red blood cells for anemia, platelets for low platelet counts.
And you mentioned something surprising about transfusions earlier.
Oh, right. Yeah. It's that generally blood transfusions from anonymous, unrelated donors are actually preferred over using blood from family members, unless it's for stem cells.
Really? Why is that?
It's mainly for safety reasons related to potential immune reactions. It seems counterintuitive, but stranger blood is often safer in this context. So, yeah, all these supportive measures are absolutely crucial for helping patients get through the intensive treatments.
This has been a huge amount of information to take in, but it really underscores how knowledge is just so critical for anyone facing a diagnosis like AL or supporting someone who is. What's maybe the biggest takeaway for someone starting this journey?
I think absolutely it's the importance of patient advocacy and engagement. Don't be afraid to ask questions. Really engage with your care team, your doctors, nurses, pharmacists. It should be shared decision making. And know that resources exist to help you. For example, the NCCN, that's the National Comprehensive Cancer Network, they publish guidelines that doctors use, but they also create versions specifically for patients. These can help you understand the expert recommendations and feel more empowered to talk about your options and participate actively in your own care.
That's great advice. And for those who are interested or maybe facing limited standard options, exploring clinical trials seems like a really vital thing to consider. Not just for potential access to cutting-edge, maybe experimental treatments, but also you're contributing to improving things for future patients. You become part of the solution in a way.
Absolutely. Clinical trials are how we make progress. They're essential. And ultimately, it's important to remember that survivorship really begins right at diagnosis. It's not just something that happens after treatment ends. It's an ongoing journey that involves continuous monitoring, managing any long-term or late effects of the disease or its treatment, and focusing on overall well-being for the long haul.
Understanding this really intricate dance between our own body cells, the glitches that cause diseases like ALL, and then these increasingly sophisticated breakthrough treatments. It truly highlights the relentless, amazing pursuit of medical science. It really makes you wonder, doesn't it? What other seemingly impossible medical challenges are going to be solved next, maybe by targeting these incredibly specific biological processes? Well, thank you so much for joining us on this deep dive into acute lymphoblastic leukemia. Our mission here at the Deep Dive is always about trying to make complex information accessible and understandable for you. And special thanks again to our sponsor, Stonefly. And speaking of innovative solutions, Stonefly now offers a 100 TB immutable and air-gap SSO NAS for just $8,995 after. That's a truly remarkable solution focused on data protection, providing really ironclad security against threats like ransomware. You can visit stonefly.com to learn more about this incredible offer. Thanks for listening, keep learning, and stay curious.